So dear students, now in this video we are going to study the endocrinology or the hormones. So starting with the definition. Now what are hormones? Hormones are basically the compounds which are secreted by specific cells and then they act away from their site of production. So this is a very specific feature about the hormones and they are produced by endocrine glands, right? So this is the definition of the hormones. Now the first gland that is important or that plays a role is hypothalamus. Now what are the hormones which are secreted from the hypothalamus? So hypothalamus secretes thyroid regulating hormone or thyroid release hormone, then corticotropin release hormone, then growth hormone release hormone, then prolactin release inhibitory hormone which is actually dopamine, okay, then gonadotropin release hormone and somatostatin. Okay, so these are the hormones which are synthesized from the hypothalamus. Then second gland which is important is pituitary. Now pituitary has got anterior lobe. There are two types of classification. I'll show you both. So we have anterior lobe and posterior lobe. Now anterior lobe से निकलता है growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, then gonadotropins that is LH and FSH. And posterior lobe से निकलता है oxytocin and vasopressin. Okay. So this is the classification of anterior and posterior lobe. Then there is another classification that is acidophils and basophils. I am telling you this because you can get a question. Anterior posterior का तो हमको पता होता है लेकिन acidophil और basophil का normally हम याद नहीं रखते हैं. So acidophils से हमारे आता है GH और prolactin, right? और basophil से हमारा आता है TSH, ACTH and LH and FSH. ठीक है? तो ये हमारे acidophils और basophils के hormones होते हैं. Then next the third gland that we study about is thyroid. And thyroid gland secretes T3, T4, calcitonin and parathormone. Now parathormone actually comes from the parathyroid gland, and calcitonin it comes from the parafollicular C cells which are present in the thyroid. Okay, then next we study about the adrenal gland. Now adrenal gland से हमारे पास आते हैं glucocorticoids and mineralocorticoids, right? Then we have pancreas which gives rise to insulin, then glucagon, and again here we have somatostatin. Then next we have testes and ovaries. Now testes से आता है testosterone and ovaries से आता है estrogen and progesterone, right? Then we also study about the pineal gland which secretes melatonin. Okay. Now coming to the mechanism of action. What are the mechanism of action of various hormones? So nuclear receptors पे कौन-कौन act करता है? Nuclear receptors पे हमारे पास है T3, T4, estrogen, progesterone and testosterone. Okay, these are the hormones which act on the nuclear receptor. Then what are the hormones acting on cytoplasmic receptor? That is glucocorticoid and mineralocorticoid. Then we have drugs acting on tyrosine kinase receptors. Tyrosine kinase receptors पे हमारे पास है insulin, growth hormone and prolactin. Okay. Then what are the hormones which are acting on G protein coupled receptors? So G protein coupled receptors पे हमारे पास हैं vasopressin, oxytocin, GnRH and TRH. So these are acting through the IP3 DAG pathway. Then second we have those which are calcium potassium channel openers. We have somatostatin. Okay. Then drugs which decrease the cyclic AMP, that is prolactin release inhibitory hormone. And drugs which increase the cyclic AMP are the remaining others hormone. वैसे तो ज़्यादा कुछ बचे नहीं. So this is the mechanism of action. Okay. Now let's start with the hormones one by one. So the first hormone that we take is called as the growth hormone. Right. So now we take growth hormone as the first hormone. Now this growth hormone basically it controls the growth of all organs except for the brainstem and eye. Sorry, except for brain and the eye. ठीक है. Then it acts by producing somatomedin, which are basically insulin like growth factor 1 and insulin like growth factor 2. So growth hormone produces its action by this. इसका एक main action होता है that it increases the glucose. ठीक है. How is it regulated? Regulation कैसे होता है? That hypothalamus secretes growth hormone releasing hormone which increases the growth hormone, and it secretes another substance which is somatostatin which decreases the growth hormone. ठीक है. Then दूसरा और होता है dopamine. Now dopamine increases the growth hormone in normal subjects, and it is seen that it reduces the growth hormone in in acromegaly. Okay, so D2 receptor agonist are used in acromegaly because D2 receptor, dopamine K receptor agonist, will reduce the growth hormone in acromegaly. And what are those compounds? They are bromocriptin and cabergoline, right? Acromegaly and also hyperprolactinoma. So any condition in which there's an increased production of hyperprolactins. We all know that GH increase hota hai, so it causes acromegaly, and decrease GH causes dwarfism, right? Now there are some compounds. Recombinant growth hormone. What is this recombinant growth hormone? It is somatropin or somatrim. Now this drug is basically used, this is used in pituitary dwarfism. In dwarfism patients, if there's a decrease in growth hormone secretion, then we give somatropin. This is a recombinant growth hormone. It is also used in AIDS related wasting, right? And also used in short bowel syndrome, which is dependent on TPN. Okay. Then next है, growth hormone can increase the intracranial pressure. So fundoscopy should be done in children at initiation of therapy. When you are starting the therapy, then because it has a tendency to increase the intracranial pressure, so fundoscopy should always be done to rule out any problem intracranially, right? Then next, now somatropin, as we have seen, it is a growth hormone analog. It is given once weekly and it is given subcutaneously. Okay. Then we have some drugs which are that is recombinant growth hormone releasing hormone. These are sermorelin, hiraxetin, and they are also used for dwarfism. Okay. Then there's a new drug, that is mecasermin. This drug is recombinant IGF-1 and IGF binding protein. Now it is given subcutaneously. It is used in growth failure due to deficiency of insulin like growth factor 1, and which is not responsive to growth hormone. Okay. The only side effect, adverse effect, which is seen with this drug is hypoglycemia. So this is the growth hormone dependent drugs which are used. Mainly they are used in dwarfism or AIDS related wasting. So now other uses. Let's see what are the other uses of somatostatin. Now other uses of somatostatin are very interesting and you should remember them. They're used in secretory diarrhea. They're used in esophageal varices. Why? Because it causes vasoconstriction, so it will block the vessels. Then it is used in some kind of malignancies due to insulinoma, and it is of course used in acromegaly. Okay. Now somatostatin is short acting, so it is not used. Instead we have octreotide, which is long acting, and so it is used. It is given by subcutaneous route. That is important. Okay. Then acromegaly, we have already seen that growth hormone is given, and growth hormone is, we give a dopamine agonist also, or cabergoline and bromocriptin. Now there is one more thing. Increased growth hormone levels करते हैं by oral bromocriptin or cabergoline or by injection octreotide. So these drugs will reduce growth hormone level. Okay, but reduce growth hormone action. What will reduce growth hormone action? It is growth hormone receptor antagonist. And what is that? That is a drug known as pegvisomant. So please remember this difference: growth hormone action and growth hormone levels. So pegvisomant is a growth hormone receptor antagonist. Okay. Then other somatostatin analogs, और somatostatin के analogs हैं, उनके क्या नाम है? उनके नाम है lanreotide, vapreotide, then pasireotide and seglitide. Okay. Now what is prolactin? Prolactin क्या होता है? Prolactin, what does it do? It causes growth of breast tissue during pregnancy and increases milk secretion. Okay. So the drug that we have, bromocriptin and cabergoline. Now these drugs are used in They are used in diabetes, type 2, diabetes mellitus. I'm telling you about the uses of these drugs. Now these, you all know they are D2 agonist. Okay, so they are used in type 2 diabetes mellitus. Then they are used in hyperprolactinomas, right? Used in Parkinsonism, used in acromegaly. Then also in whenever there is a milk secretion, they are used, and inhibition. Now cabergoline, इसमें important है. Cabergoline की half life is around 60 hours, so it is the longest acting. Okay. Now adverse effects में देखते हैं. तो bromocriptine के early adverse effects usually nausea, vomiting, hypotension. These are the adverse effects. But if you give it for a prolonged duration, then it causes behavioral abnormalities, hallucinations, and abnormal movements. So this is something which is seen with bromocriptine. Now let's come to the next part, that is GnRH. Now there are two types of GnRH. One is FSH, we all know. One is LH. We all know LH causes ovulation. LH surge होती है, ovulation होता है, right? Now इनकी what is the feature it is seen in deficiency? It causes infertility. And what is another thing? They cause hypogonadotropin, hypogonadism, right? And when there is excessive, then it results in precocious puberty, endometriosis, fibrosis, and also PCOD. These are the features which are seen by deficiency of GnRH and by excessive GnRH. Okay, now there is something called as synthetic GnRH. Now what is synthetic GnRH? It is called as gonadotropin. Right? Now synthetic GnRH is gonadotropin, and it is actually used to differentiate between pituitary and hypothalamic deficiency in patients with hypogonadotropin hypogonadism, right? So इसमें if LH is more than 10 milliequivalent per ml after giving GnRH, then it indicates pituitary. ठीक है? Indicates that pituitary is normal. ठीक है? So ये हमारे दो तरीके के gonadotropin releasing hormones होते हैं. अब हम इसके ऊपर based drugs देखते हैं. Let's see the drugs which we give on the basis of these. So GnRH हैं, इसके हमारे पास होंगे, we have antagonist and we are talking about the agonist, right? Now antagonist to GnRH will do what? It will reduce LH and it will reduce FSH. That will further reduce estrogen, progesterone and testosterone. So antagonist to GnRH, they are used in prostate carcinoma and they can also be used in endometriosis. Okay. Now agonist हमारे पास दो तरीके के होते हैं. One agonist we give in pulsatile fashion and one agonist we give daily. Now this is the most important part. The most important part of GnRH, that when you give pulsatile, it will increase LH and increase FSH, which will further increase estrogen, progesterone and testosterone. So this pulsatile fashion can be given in anovulatory infertility, okay, and delayed puberty. So when you give gonadotropin releasing hormones in pulsatile fashion, you can use them in infertility. Now when you give them as a daily basis, then it will result in blockade or reduce the secretion of LH and FSH over a period of time. That will again reduce estrogen, progesterone and testosterone. So again they can be used in the same indications like this. So they can be used in prostate carcinoma, then endometriosis, and then fibroids, and they can be used in precocious puberty also, where you want to reduce the LH and FSH. So these agonists are working same as antagonist, right? Now you will say फिर difference क्या रहा मैडम इनमें दोनों में? तो difference मैं बताती हूँ. जो agonist होते हैं ना, इनमें flare up reaction होता है, because initially they will increase the secretion and then afterwards they will reduce. While in antagonist there is no flare up reaction. Okay. Now antagonist के नाम क्या होते हैं? Cetrorelix, then Ganirelix, then Abarelix, then Digarelix. Okay. And we have Elagolix. This is used in patients who are having painful endometriosis and they are given orally. Then another drug is there, Relugolix. This is also given orally. Now this drug is also used in vivo in IVF, in vivo fertilization. So these drugs are also used in vivo fertilization to reduce the ovulation. And Relugolix is used in prostate carcinoma also, right? Now what are the GnRH agonists? What are the agonists here? Let's see their names. Leuprolide, Nafarelin, Buserelin, Goserelin, Deslorelin, Triptorelin and Hystrelin. Okay, so these are the drugs. So you can understand this, that same drugs. Please remember this: pulsatile में देंगे तो इन इंडिकेशंस में, अगर डेली में देंगे तो ये इंडिकेशंस है। एंटागोनिस्ट यहाँ पे, एंड एंटागोनिस्ट हमने आपको नाम बताए हैं सारे। द न्यूअर ड्रग्स आर रेलिगोलिक्स, सिलाकोलिक्स व्हिच आर यूज्ड इन विवो फर्टिलाइजेशन, endometriosis, prostate carcinoma, and these are the drugs which are agonists, which are also given for the same. The only difference is that these can cause flare-up reaction, these do not cause flare-up. Now let's see the thyroid gland, thyroid hormone. Now coming next to the thyroid hormones. So after completing the hypothalamus and pituitary, we discuss about the thyroid hormone. Now thyroid hormone में जो follicular cells होते हैं, they secrete T3 and T4, and parafollicular C cell secrete calcitonin. Okay. Now what is the mechanism of making of thyroid hormone is that there is a NEET, sodium iodine symporter. So sodium iodine symporter is there at the follicular cell, and this causes the entry of iodine ion inside in exchange with sodium. Right. This iodine then, so I'll write here, iodine is first taken up by the cell by NIS, that is sodium iodide symporter. Then this iodine is oxidized to iodinium, that is I plus ion. Now this iodinium ion combines with tyrosine and it forms MIT and monoiodotyrosine and diiodotyrosine. Okay. Now this is called as organification of iodine. Now once this is done, after the organification, this monoiodotyrosine and diiodotyrosine, they undergo coupling. Coupling में क्या होता है? DIT plus DIT becomes T4 and MIT plus DIT becomes T3. Okay. Now this particular thing is then transported to the center of the follicles and it is stored as colloid. Okay. Then after that, whenever there is a requirement, a signal is coming, then they move to the surface and then they are secreted. Once they are in the secretion, once they are in the blood, then they are taken up by liver and kidney, and there another phenomenon occurs, that is peripheral conversion of T4 to T3 occurs, and then the T3 is taken up by target tissues, right? So this is the whole cycle of thyroid hormone. Now a very important thing, that all these reactions, oxidation, combination and coupling, are mediated by an enzyme, and that is called as thyroid peroxidase. So this thyroid peroxidase become a major target for our drugs, because this is the hormone which is playing this is the enzyme which is playing a major part in production of thyroid hormone. Now a few points of comparison between T3 and T4. Now T3 is more potent and more active, plus it is short acting, so beneficial only in emergencies like myxedema, coma, while T4 is less potent, but it is the main circulating hormone and it is long acting, so it can be used for long term use, right? So T3, also called as liothyronine, iska only indication in clinical application is myxedema, coma, right? But it is not used as it can cause cardiac arrhythmia. Why it causes cardiac arrhythmia? Because it sensitizes the heart to adrenaline, to the sympathetic action of adrenaline, so it makes the heart more sensitive, right? So T4 is the hormone which we use in hypothyroidism and cretinism and myxedema, coma. Okay, is this clear? That T3 is not used, T4 is used in all these conditions, right? Then next we have the anti-thyroid drugs. Now anti-thyroid drugs ka classification, let's see. So the first category of drugs is thyroid peroxidase inhibitors, right? So thyroid peroxidase inhibitors. Now in this, what are the drugs that we have? We have propylthiouracil, we have carbimazole, and we have methimazole. Okay. Then after that, the second category of drugs that we have are called as iodides. So in iodides we have potassium iodide, sodium iodide, Lugol's iodine, and in general iodine. Then the third category of drugs is radioactive iodine, in which the drug is iodine 131, right? Iski half-life is 8 days. Then there are drugs which are peripheral conversion inhibitors. So in this, again, propylthiouracil is the drug. Then propranolol also inhibits the peripheral conversion, and there's another drug that is called as amiodarone that also inhibits the peripheral conversion. Okay. Then next क्लासिफिकेशन में ही आगे हम बढ़ते हैं. Adjuvants में we have propranolol, diltiazem. Adjuvants as in these are drugs which can be used in hypothyroidism. Then next category is drugs which are inhibitors of sodium iodide symphoter, and that is thiocinates, perchlorates and nitrates. Right, so this is the classification. Now let's understand one by one. First thing, these drugs are very toxic, so they are obsolete. Okay, then carbimazole. I'm telling you important points of these drugs. Carbimazole is a prodrug and it is converted to methinazole. Okay, another important point, questions are asked very commonly on this, that propylthiouracil is used in first trimester of pregnancy. After that, propylthiouracil is only used in the first trimester of pregnancy. After that, the drug which is used is methimazole. Methimazole is used because propylthiouracil does not cross the placenta, and so it is not toxic to the child. But prolonged use of propylthiouracil can result in hepatotoxicity, so we don't use it for a long time. Then another thing, very important thing, is that the thyroid peroxidase inhibitors, इसमें they can cause reversible agranulocytosis. That is their side effect. The most common side effect is that they can cause maculopapular rash. Then another important thing is that iodine 131 is not used because, see, iodine 131 is radioactive iodine. It will cause permanent destruction, right? And so because it will cause permanent destruction, it will cause permanent hypothyroidism, and the patient will have to take thyroid hormone T4 for whole life. Okay, so it is not used in pregnancy, lactation and in children. Okay, so this is something important for the profile, this thing, iodine 131. Then if there is thyroid storm mein the anti-thyroid drug of choice is propylthiouracil, right? And drug of choice is propranolol. Why? Because it is having a beta 2 anti action. Beta 2 blocker है ना, इसलिए it will reduce the symptomatic effects. Then propylthiouracil is also preferred in young adults, and also to make the patient euthyroid before radioactive iodine. Okay. Then iodides जो होते हैं, iodides, Lugol's iodine. What is Lugol's iodine? It is 5% iodide in 10% potassium iodide. Now this acts as, they're called as thyroid constipating agents. Okay, they are the fastest acting drugs, and they can be used preoperatively to prepare the thyroid gland for surgery or for radiotherapy, because they'll shrink the thyroid gland. But in basically when you give Lugol's iodine and iodides for a long time, then there is a thyroid escape. That means for some time there'll be reduction, but after some time then they'll escape and there'll be a huge secretion of all the thyroid gland, thyroid hormones, right? Chronic overdose होने पर it can cause iodism. And what does iodism presents as inflamed mucous membranes, increased secretions, rash, GI distress, etc. It can also result in flaring up of acne in adolescents. Okay, now next we take radioactive iodine. Radioactive iodine कैसे देते हैं? What is the process of giving radioactive iodine? Now radioactive iodine में first thyroid peroxidase inhibitors are started, then they are stopped, and after a gap of 5 days radioactive iodine is given and thyroid peroxidase inhibitors are started. Okay, thyroid peroxidase inhibitors are given till the radioactive iodine effect starts. Okay, so this is how radioactive iodine is given. Then it is used in patients older than 35 years. Okay, not suitable, that I have told you, and it results in permanent thyroidism. So this was about thyroid hormone. The next that we are going to start with is diabetes mellitus. Coming to the next disease, that is diabetes. Now diabetes mellitus is a big topic, and it is going to take a lot of time. Now in this, the alpha cells of the pancreas, they secrete glucagon, the beta cells of islet of Langerhans secrete insulin, and the delta cells, they secrete somatostatin. Okay. Now diabetes mellitus mein the sugar level in fasting should be more than 126, pp more than 200, and HbA1c more than 6.5. Then if these parameters are fulfilled, then it is called as diabetes mellitus, right? Then we have type 1 diabetes, in which only insulin is the drug of choice, and then we have type 2 diabetes mellitus, in which oral agents are given plus insulin is the treatment of choice. Now insulin, we all know that insulin has got 51 amino acids chain, out of which A chain is having 21 and B chain is having 30 amino acids, right? How is insulin secreted? Secretion of insulin. Now secretion of insulin depends upon the stimulus. So glucose is the stimulus, right? So glucose is the stimulus. It attaches to GLUT2, that results in increased ATP, and that inhibits the ATP sensitive potassium channels, okay? And as a result, there is depolarization and release or opening of calcium channels, and this results in secretion of insulin, right? Then if we see about the regulation, so insulin increased release is done or controlled by glucagon, vagus, and even beta-2 adrenergic receptors, while insulin decreased release is mediated by somatostatin and alpha-2 agonist, okay, right? Now what is the action of insulin? Insulin की action कैसे होती है? Insulin, when insulin attaches to the receptor, we all know it is a tyrosine kinase type of receptor. So insulin first of all increases GLUT4 synthesis and translocation to the cell membrane of this GLUT4, to which the glucose then attaches. It then decreases glycogenolysis, it increases glycolysis, and it reduces lipolysis. Okay? So these are certain things which you need to understand when the basics of insulin and diabetes mellitus. Now let us come to the preparations of insulin. So what are the various preparations of insulin? Now in that, the first part is rapid acting. Now rapid acting insulin mein we have Lispro, Aspart, and Glulysin, okay? Then short acting insulin mein we have regular, which is given IV, and semi-lente. Then intermediate acting insulin mein we have NPH and lente, and long acting insulin mein we have ultra lente, Glargine, Detamir, and Degludec, okay? Now important यहाँ पर है कि Degludec causes peakless insulin. It has very low risk of hypoglycemia, okay? Another important point, all insulin preparations are acting at neutral pH except Glargine, which is supplied at pH less than 4 or pH of 4, okay? Now next we come to all preparations of insulin are given subcutaneous, right? All preparations of insulin are given subcutaneous except regular insulin, which is given IV. Then next point is all preparations are given on abdomen except 2 inches around umbilicus. Okay? Apart from that, they are also given on anterior and lateral thigh, and also given on arm. Next है inhalational insulin causes lung cancer and fibrosis, right? So there is something called as diabetic ketoacidosis, which is an emergency condition. उसमें the insulin that we use is regular insulin by IV route. ठीक है? Now coming to the areas of insulin. Insulin के areas बहुत common है. First is very well known areas, hypoglycemia because it produces glucose. Then it causes hypokalemia because insulin has a tendency to drive potassium inside the cells, and then lipodystrophy at the site of injection. However, this is very less with the recombinant insulin that is nowadays available. Then if we come to the drug interactions, now there are many interactions related to insulin because insulin is managing the blood sugar. So the first interaction is that the beta blockers cause dangerous hypoglycemia. Why? Because they mask the sympathetic effect of hypoglycemia. Now, an important part here is except one symptom, that is sweating. So except sweating, they mask all the symptoms because this is mediated by cholinergic fibers, right? Then second होता है acute alcohol ingestion causes hypoglycemia. Then some drugs increase glucose and so they reduce the effect of insulin, which are diuretics, corticosteroids, OCPs, diazoxide. Okay, so these are some drugs which will inhibit the action of insulin. Then coming to DK. DK में there is hypoglycemia, ketonuria. It presents with hypoglycemia, ketonuria, and metabolic acidosis. Right? Now the treatment is सबसे पहले IV fluids. They are very important. Plus regular insulin is given at the rate of 0.1 unit per kg per hour. IV. Okay. A very important point in this, in children, you start insulin 1 hour after giving IV. So insulin is to be started 1 hour after giving the IV fluids. Okay? This is important. Many questions are also asked over this. Then next we have is glucagon. Glucagon. What are the uses of glucagon? It is used in hypoglycemia. Okay? But it is not useful in hypoglycemia caused by alcohol or starvation. In that it cannot be helpful because it causes hypoglycemia by decreasing the gluconeogenesis. Sorry, it increases the glycogenolysis. So in starvation and alcohol there is no glycogen which will be broken down, so this becomes ineffective. Then second most important use is it is the drug of choice in beta blocker toxicity. Okay, how does it act? It stimulates the glucagon receptor. Okay, so this is the important point related to beta blockers. Next, so insulin is used. एक तो हमने देख लिया IDDM में. Second, NIDDM में नॉन इंसुलिन डिपेंडेंट डायबिटीज में कब यूज होती है? It is used when there is infection, stress, surgery, and pregnancy. Okay, and third, it is used in hyperkalemia. Okay, so this was about insulin. Now let's come to the oral hypoglycemic drugs. Oral hypoglycemic drugs. There are 2 points also, but we'll take चलो बाद में लेते हैं. Now oral hypoglycemic ले लेते हैं. हम यहाँ पे बात कर रहे हैं पेरेंट्रल की. तो पेरेंट्रल में ये पूरा क्लासिफिकेशन है. ये इंसुलिन आता है, एक आता है GLP-1 एंड थर्ड आता है amylin analogs. So in amylin analogs we have the drug which is called as pramlintide. GLP-1 में we have liraglutide and exenatide, right? Then we come to this part, that is oral. Now oral में the drugs which release insulin, these are also called as insulin secretagogues. So इसमें the first category of drugs that we have is sulfonylureas. Then the second category of drugs that we have is meglitinides. So sulfonylureas में again we have first generation and second generation. First generation we have chlorpropamide, tolbutamide. Second generation we have glipizide, gliclazide, glanepiride, all these. Meglitinides में we have 2 drugs, that is rapaglinide and nataglinide. Okay, then the third category, now this is consisting of lot many drugs. So here the first category is biconides, right? So biconides, इसके अंदर आती है metformin and fenformin, right? Then the next category of drugs is thiazolidine in which we have pioglitazone, rosiglitazone. So these are the drugs here. Then we have alpha glucosidase inhibitors, right? Now in alpha glucosidase inhibitors we have acarbose and miglitol. Okay, then a new, like they are just introducing this as something that can be used in diabetes, that is bromocriptine. Then a very important category of drugs is DPP-4 inhibitors, right? So DPP-4 inhibitors में we have sitagliptin and vildagliptin, right? Then we have SGLT2 inhibitors. So in SGLT2 inhibitors we have dapagliflozin and empagliflozin, canaflozin. Okay, इसके अलावा GLP-1 analogs में भी हैं the drug which is taken orally, approved orally, is semaglutide. Right, so this is the classification. You can see from here it starts oral and parenteral. So insulin secretagogues are sulfonylureas and meglitinides, and then drugs acting by other mechanisms are bigonides, thiazolidine then alpha glucosidase inhibitors, dopamine agonists, DPP4 inhibitors, GLP-1 analogs, and SGLT2 inhibitors. Okay? So now let's take these drugs one by one. We'll only discuss the important points related to these drugs. So coming to the sulfonylureas. Now sulfonylureas are drugs which inhibit the ATP sensitive potassium channels, right? So by that action they cause depolarization and they cause release of insulin. So sulfonylureas cause release of insulin, so it is a secretagogue. Now in sulfonylureas we have drugs like tolbutamide, which is shortest acting, and chlorpropamide, which is longest acting, right? The second generation compounds are more potent, then they also cause weight gain, and these drugs also have a tendency to cause hypoglycemia. Okay, now specific side effects of chlorpropamide, which are very commonly asked as a MCQ also. Chlorpropamide causes dilutional hyponatremia, it causes cholestatic jaundice, and it also causes disulfiram like reaction. Okay, now this is very specific related to chlorpropamide, so please remember this. The next insulinogogue secretagogue is meglitinides. Now these meglitinides also cause release of insulin, they also cause weight gain, and they also cause hypoglycemia. ठीक है, so meglitinides में ऐसा कोई अलग से कोई बहुत specific features है नहीं. Next we have bigonides. Now bigonides में हमारे पास जो drugs हैं वो हैं metformin and fenformin. Now metformin is basically known to cause megaloblastic anemia, and fenformin is known to cause lactic acidosis. Okay, now these are basically they activate AMPK, right, because of which they reduce the production of glucose and increase the utilization of glucose. That is their main action. Okay, then lactic acidosis ये मैंने बता दिया, megaloblastic anemia बता दिया. Metformin also interferes with calcium dependent absorption of vitamin B12 and its combination with intrinsic factor. Then lactic acidosis is more severe in hepatic and renal impairment. Okay, apart from that, metformin is also used in PCOD, and this is the only oral agent which reduces macrovascular events, right? So this is the first line therapy for NIDDM or non-insulin dependent or type 2 diabetes mellitus. The next category of drugs that we have is thiazolidine diones. Now these thiazolidine diones are basically agonist of PPAR gamma. So they are the agonist of PPAR gamma receptors, and they are seen to reverse the insulin resistance, and they also increase the HDL levels. Now the first drug, troglitazone, was withdrawn because it caused hepatotoxicity, right? Glitazones are also known to cause weight gain and edema. Okay? Then pioglitazone is also known to be associated with bladder cancer. Okay? Then next category is alpha glucosidase inhibitors. इसमें जो ड्रग्स हैं वो हैं अकारबोस, मिग्लिटॉल, वोग्लिबोस, and the side effects which are caused by these drugs are flatulence, right? Then one more thing is there, acarbose is not absorbed from GIT, so it has got no systemic toxicity, but miglitol is contraindicated in renal failure as it gets absorbed and causes systemic toxicity. Okay? Then there was this category of drug which was amylin analogs. So इसमें जो drug आती है amylin analogs, that is pramlinitide. Pramlinitide is the only drug other than insulin which is approved in both type 1 and type 2 diabetes mellitus. So pramlintide is the only drug which is approved. ठीक है? Amylin analogs basically क्या होते हैं? There is a substance called as IAPP which is secreted along with insulin, and amylin analogs they act like that. So this pramlintide is given subcutaneously. It is known to decrease glucagon, decreases appetite, and decreases the gastric emptying also. Okay? अब आगे बढ़ते हैं new drugs. So in this new drugs में we usually study the incretin mimetics. Now this incretin mimetics, incretins are substances which is secreted in the GIP after food, and they cause increased release of insulin, plus they also reduce the appetite and they also reduce the gastric emptying. Now we have two type of incretins, GIP and GLP 1 and 2, right? Now GIP or GLP, they are metabolized and broken down in by an enzyme which is called as DPP4, and this DPP4 is inhibited by DPP4 inhibitors. Because so there are two type of drugs which we mainly study here. First is GIP or GLP-1 analogs, and the second category that we study is DPP4 inhibitors, because these are the drugs that will reduce the breakdown of GLP and GIP-1 and will continue their actions. So these DPP4 inhibitors में we have gliptins, that is sitagliptin, vildagliptin, all these, and in GLP GIP analogs we have types, exenatide, liraglutide, semaglutide, like this. Okay, so इनके बारे में तो हमें पता ही है. There is a new drug, lixisenatide. Now this lixisenatide is given once daily. It is a GLP-1 agonist. Okay, what is the ADR? It is contraindicated in medullary thyroid cancer. Then another drug is there, semaglutide. Semaglutide is basically approved for type 2 diabetes mellitus, right? Then there is another drug, teduglutide. Teduglutide is a GLP-2 analog, and this drug is indicated for short bowel syndrome patients. Okay. Then DPP4 inhibitors. Now what are these DPP4 inhibitors? They basically increase the action of GLP-1. The most common adverse effect which is seen with these is nasopharyngitis, and they also cause acute pancreatitis. Okay. Then the last category that we have is SGLT2 inhibitors. Now SGLT2 inhibitors क्या होते हैं? Basically, like if this is the cell, this is the blood, and this is the lumen. So there is a SGLT2 transporter, and this SGLT2 transporter causes reabsorption of glucose along with reabsorption of sodium, and this glucose is then further reabsorbed in the blood. So SGLT2 inhibitors, this is called as SGLT2. So इसको वो inhibit करेगा, SGLT2 inhibitors, right? So they will reduce. They are doing what? They reduce the reabsorption of glucose, right? What are the adverse effects? They cause UTI. They also reduce the bone marrow density, and they also reduce the cardiovascular mortality. So these are the, this is a good effect, but these two are adverse effects. Then lately, like bromocriptin, which is a D2 receptor agonist, has also been approved for the use in diabetes mellitus, and bile acid binding resins, which is colesevelam. This is also used. This can cause hypertriglyceridemia. So colesevelam is the bile acid binding resin which is used in type 2 diabetes, and this can also cause hypertriglyceridemia. So with this we complete the diabetes part, and let's take the corticosteroids now.